access.
Yeah, so this talk is it's sort of in two parts, just a general technical discussion about, for laparoscopy, how we access the peritoneum. And then at the end, Liz is going to focus on a particular problem that we need to be aware of and figure out how to address. So just get started, for a 10-year-old with appendicitis.
What does dissection clamp passage mean?
That's what you do.
Clamp passage? What is
Your hemostat, when you pass your hemostat down through the umbilical fascia.
Pass a clamp.
And then you take your clamp back out, and then you come back in with the needle, right?
Yeah. But I don't do that in a 10-year-old, by the way.
Okay.
That's only while we're waiting for the answers to come through. I only do that in 4-week-old pylorics. Once they're older, I do
Veery's needle.
I do various.
So you would have picked B.
I would B.
All right.
B, or if I do a Hassan, it depends. If it's an extirpative for a gallbladder, I'll do Hassan.
So just polling the other people in the room, Mark.
B.
So we're
Just Veery's needle through the fascia in a 10-year-old. That's what we're talking about.
Yeah.
What?
A.
Open a
dissection.
okay.
You want to vote?
No.
How do you get? What do you do? How do you get access?
How do I get access?
Yeah.
I just do direct entry with visualization in my adults.
So OptiView.
OptiView.
Okay. Does anyone else here use? I did it for my first time last week. You use OptiView quite a bit, right? Okay.
It's a good thing to use if you're not going through the umbilicus.
Yeah.
I did it through Palmer's Point
this
past week.
Right.
Yeah.
All right. Well, we'll keep
But I
going.
varused first. I varused first to make my
To
OptiView
distend it.
safer.
To distend the abdomen.
Yeah, and then I did it.
One option that you didn't have on there, and I'm shocked, is sills. Okay.
Or forget all that other stuff. Would you have done a single site approach, either the SIPES, which is the bottom left picture, or a Tula, which is where you pull the umbilicus out of the the appendix out of the umbilicus, and do an appendectomy on the outside. So, what? What do you say?
Then put the scope in and do the rest of the appendectomy. So I do it two different ways. So I'll do an operative laparoscope through the umbilicus, or put the camera and a grasper through the umbilicus, grab it, pull it up. But either
It
way,
says classic Tula. The second one is the
I do
classic Tula.
extracorporeal single incision appendectomy.
So you make Dan happy because you're the cheapest appendectomy in the
Is that right?
hospital. Yeah. We don't know what percent of the total population voted for this, do we?
Now, a lot of it depends on the body habitus, wouldn't you say?
No, it depends on the surgeon.
Okay.
Surgeons they're very committed to their one or the other.
Okay. I would disagree with that, but that's okay.
We've disagreed before.
I want to hit on what Whit just said. So I will adjust what I do based on several different factors. Some say always do the same thing no matter what. I will, if they're large body habitus, I will do a 3-port appendectomy. I won't even try single port.
And we published papers on you can take the 90th percentile and above pediatric population and do SIPES appendectomy just as well as 3 Trokar. So wound issues, all that stuff. So, FYI.
It depends if you're doing an intracorporeal or an extracorporeal single port appendectomy.
Not if you have a wound protector, it's the same. In fact, it's better if you have a wound protector.
That type of trocar we use has a plastic lining, so the appendix never touches anything as it comes in.
Yeah.
So this question was, when it's time to pass your needle in your trocar, do you pay attention to the direction it's going? Do you try to go in and up toward the spleen, in and up toward the right, in and up toward the left, straight up, or do you go straight down?
I go up. I lift up on the umbilical stalk and then I poke superiorly.
Superiorly in what direction?
You mean left or right?
Yeah.
Superiorly straight up.
Ooh, that's the wrong answer.
I know what you're getting at, but I still do that.
All right. Any other comments about this? I learned from Keith Jorgensen to go in and toward the spleen. So
Is that right?
That's what I do. So
Well, that's the natural inclination for a right-handed person.
If you're a right-handed person, stand on the right-handed side of the. In fact, even if I'm going to help a resident or fellow, I oftentimes stand on the right to put the first trocar in, and then we move to.
Yeah, it just
To
depends
let
which
them do
side
it.
of the patient you're
Well, I know I'm going to do it safest.
Okay.
So straight down, that's not. I would say that's not really what we want. It's amazing, isn't it? Especially in some bigger obese people and teenagers, the distance between the posterior fascia and the umbilicus and the aorta is about this far. and intestines lying on top of that.
So I think a lot of this is just how you insert your varus. I generally do not go more than a millimeter. Like that, get that loud audible click. For me, it's that I have a loud varus needle, because there are different brands of varus, and I like the ones that make a very loud audible click after you pass the peritoneum.
I agree with Todd, and I hold the needle at the bottom.
So do I. Yep.
And you ever helping a resident or fellow and all of a sudden go, oh, they went in too far. You don't have that?
That's why I do the Hassan technique.
That's what I do too. Yeah.
Say that again, Mark.
We
I'm
all
sorry.
hold it
Repeat
like a
Todd.
dart,
Yes. Yes.
very close to the tip.
All right.
I think you touched on the reasoning for not going straight down, but it's because in whatever direction you want to go to outside of straight down, you've got much more space to insert the trocar and the cannula.
Yes. And if you go straight down when you put your telescope in the first time, oftentimes I notice people start looking around, did I poke a hole in something?
You know, Scott Bollinger, my partner in Akron, made a quote once that I think is very true. All of these things are great. All of these things are important. The key to success is that when you keep doing the same thing over and over and over again is how you minimize. It's when you start trying new tricks and techniques is when you end up getting injuries. So when you put your thing in a different location than you normally do, that's when you cause problems. If you do the exact same thing every single time, you usually are safer.
But there are areas in the abdomen that are safer, right?
Correct.
If you're poking straight down, the thing that's there, like Mac mentioned, the aorta, the
cable.
most frightening thing are the iliacs, right? You get the iliac vein and you're going to have a really bad mess. And there's no iliac vein in the left upper quadrant.
Yeah, but it's okay. I mean, it's very rare that I'd be putting the varus needle in much more than a couple millimeters. If it is, I would do a Hassan.
But
if
then-
I felt like it's someone I couldn't, if it's not a very thin patient that I could know that I'm just a couple millimeters in and hear the click, then I would do a Hassan. I don't do the varus unless it's an easy varus.
But the question is not just the varus, but it's the port, the trocar and the cannula.
Oh, which direction you insert the
Yeah, it's
trocar
both.
in.
Yeah.
Okay.
And just to comment on if you do it the same way every time, how do we then ever innovate?
So I guess there's migration to what you would call a safer technique. I'm talking about the cases I've heard about people getting injuries is when they have done things like insert them in different places where they're not used to and know the feel of it when they've got an injury. If you're trying to modify the technique to make it safer, like which angle you point it in, I think that's probably not going to cause much harm.
If you use the sheathed Veres needle approach, do you insufflate before passing the trocar?
I don't use sheathed.
You don't use a sheath.
Not
Do
first.
you still
First.
use step trocar?
Well,
I-
we're not using the step anymore, but with the open Hassan, I would just put the sheath in without the varus and then put the cannula through the sheath.
and not before, and then insufflate.
Yes.
So if you do a Hassan, you can either make the incision on top of the umbilicus, right through the umbilicus, or under the umbilicus.
At our place, we generally make a vertical incision right through the umbilicus, except in the neonate now.
And what do you do in the neonate?
Well, I try to make an infraumbilical incision.
Okay. Liz, what do you do?
Through the belly button, see the peritoneum and see that you're actually in the abdomen.
So you
Through the
make your
umbilicus.
skin incision through the umbilicus.
Skin incision through the umbilicus.
Then what?
And through the peritoneum, and then put the
Wait.
sheath in.
So you're cutting down through the. You're assuming that
In the babies.
in the babies,
So in older, if this is
16-year-old.
yeah, then they're getting a sills. We do
How do you
almost
make your?
everything.
How do you get access to your sills? How do you make?
We
your-
make an incision through the umbilicus.
Through the
It's
middle.
open.
It's
it's
a mini
it's a-
linea alba midline incision.
It's a DPL incision, right? When we were doing diagnostic peritoneal lavage back 1,000 years ago.
Yep.
It's the same thing.
No one knew what that was.
Right. So
The dinosaurs are roaming the earth.
Okay, now we're focusing on specific patients. So a 2-day-old with duodenal atresia, the same question we asked at the start about how you would get into the peritoneum.
Duodenal atresia, I'll do an infraumbilical incision because it's gonna be a newborn with a wet umbilicus, and you really need to be careful you don't cannulate the umbilical vein.
and then how do you? So you make an infraumbilical skin incision, and then how do you get into the belly
And I put a Veres needle through
without a sheet?
without a sheath. Yeah, I think that the step trocars are not designed to be placed with the sheath in. because it's a big step off, a big change in diameter. And I really worry that you'll deflect the abdominal wall and injure something. So I think if you use a step, you should always put the Veres needle in first, safely insufflate, then put the Veres needle with the sheath in to insert your sheath.
I do the same.
So
I've never heard of that.
Yeah, I do the same. It was a Steveism.
Just never heard of that.
Yeah, it's a much more, it goes much more slick and smooth when you put the Veris without the sheath. The sheath adds that little obstruction to it. Huh?
That's why I won't use that Trokar, because I can't stand that step off. Now, I've never tried just putting in the
Veris
Veris
first.
first, because that's what I do anyway.
Yeah.
So Mark, a real technical point here, if we can get in the weeds a little bit. Do you think you can make that umbilical incision and still come at an angle with your Veres needle that you could get the vein? Or or now we're back to going straight down, and you
You're
feel like
not
you're
going straight down.
a
So-
centimeter below the center of the belly button.
So, and with a little baby, you can actually, it's something that, remember Keith used to do this all the time. You can grab the umbilicus and just lift it up. If you want to do the towel clamp trick, you can. But I think that if you remember, the umbilical vein is going to come up through the center of the umbilicus. If you go below, you shouldn't be hitting that orifice. I think the danger isn't that you're going to, somehow go in the belly and then cannulate the umbilical vein. I think the danger is that you're just going to go through the orifice, or the obliterated orifice of the umbilical vein, which is at the base of the umbilicus. So if you go below that, you should be, in theory, outside of the umbilical vein.
So this is what's interesting. I'm thinking now, what are the risks that get you into the umbilical vein, which we're going to talk about. But that's what I do exactly every time, and this is why I go superior. So I grab the umbilical stalk with a coker or a snap, lift it straight up, and I try to go perpendicular to, now the fascia, instead of flat, is like this, and I go perpendicular to that every single time.
And that's what I do.
You do the same.
Yeah, I do the same.
With just a Veris, without the
Got
sheath.
it.
Yeah.
Yeah. High five on that.
Okay.
Yeah.
Be on the highlight clip.
Oh yeah, 50.
50% don't need to worry about what we're talking about.
Right, because they do it over. Yeah.
But see, I worry that a quarter do dissection and clamp passage into the peritoneum and then a Veres, because I worry that you can open up open up the umbilical vein. But I think for those that do that, you just need to be careful and know that you're popping into the peritoneum.
All right,
Well, I
keep
think the
going. Yeah. Oh, go
important
ahead.
point, I think Liz may get into this a little bit more, is that at least from my knowledge, until about a year ago, I didn't know about this potential complication. And maybe that's my ignorance. That is of either cannulating the umbilical vein or getting CO2 in the umbilical vein.
You're going to talk about this next, right?
And so to me, it's really interesting that we've been doing this for over 20 years, and this devastating complication is really just coming to light, or just becoming knowledgeable to folks.
So what Dr. Holcomb's referring to, just to say it, because Dr. Byerly is going to go into depth on this, is that in the last year, there has been a lot of recent discussion among some of our colleagues who have seen a lot they've heard of a lot of cases or seen cases of when the access was made, there was air entry into the umbilical veins, causing an air embolism. And that's what
A CO2 embolism.
a CO2 or
air.
which is a big problem, and that's what I'm stealing Dr. Byerly's thunder, but that's essentially a big reason of why we're talking about this right now.
That's where we're going.
And Whit's point was that, why is it that I have never heard of it before this year, you've never heard of it before this year, and now all of a sudden everyone's talking about it? So
It was a hot topic at IPEG. That's where it came up. Dr. Rothenberg presented.
right,
It's
but
12 cases.
but we didn't hear this from Steve until about a year and a half ago when he started talking about it. Before that, I'd never heard.
I heard of a case 2 or 3 years ago as the first one, and have heard of 3 or 4 or 5 more since then. And he says 15 that he knows about.
Right. Yeah. All right. We'll get, because we're way behind now. So
Okay, I'm sorry. We'll hurry
Yeah.
ahead. How about a 4-week-old with pyloric stenosis? Same question about access. Anything different here? 2-day versus a 4-week. Cord's a little better.
So I'm
Make it-
D here, but I'm not D. Sort of. I am dissection past the hemostat and then put a port in.
Okay, you make the hole big enough to just drop
Yeah.
the port in. Okay.
Yeah.
So although there's no prospective randomized trial on this, at what age do we think we don't have to worry about
The
this?
umbilical vein.
Yeah, the umbilical vein being
It's a
problematic.
great question.
Steve says 2 months. So I don't know where he got that.
I can tell you where he got it. Out of his back pocket. Sorry, Steve.
Well, look at that. That's amazing there. Sort of a 4-way split. Interesting. All right, here's the case. As you access the peritoneum for a pylorotomy in a 4-week-old male with pyloric stenosis, the patient becomes bradycardic, hypotensive, and drops his end-tidal CO2. You immediately worry about. I hope this answer is straightforward. So just a 30,000 foot CO2 embolization is a rare event. It happens in adults, but it's not usually the umbilical vein. It's just like, can you imagine a varice near the umbilicus? And somehow you get just into the venous system and blow CO2. Clinically significant embolization results in a mortality of 25%. Some people have discussed transesophageal echo urgently to try to help figure out what's going on. Immediate treatment options that people try are immediately desufflate, put yourself in Trendelenburg, a central venous line to suck out the gas. And I know of several cases who have gone on ECMO emergently at the start of the pyloromyotomy. So be aware, we don't really know the incidence in babies, but the impression is that it's real and deadly. Pediatric surgeons should be working on a technique that lowers the incidence, and thus the reason for these discussions. I believe now when I use a sheath, but I always put the trocar in before I insufflate, look with the telescope, make sure I'm in the peritoneum, then put on the insufflation. But I have to say, Steve Rothenberg, who's worried about this, believes that you can get CO2 embolization without necessarily just having your needle or trocar in the vein. He believes somehow there's a way to damage the vein on the way in and insufflate into the peritoneum like you're supposed to, but have the CO2 rush back up and go through the vein. And so the open technique may be the safer way, a la what Whit has described as the inferior Hassan.
Well, so, and I don't know this information, but does anyone have any impression of is this occurring with a variety of techniques, or is it maybe one technique that's happening? I don't know the answer to that.
Well, again, Steve, because he and I have discussed this a lot, would say anybody who's not doing an infraumbilical incision, doing a Hassan approach straight down, all the other techniques are at risk, is his opinion.
Right. And I don't think we know
So-
what's right. Okay.